Now, Professor Stern did a really good PowerPoint. I think that really summarizes the main point here about, what meds are approved for what, but I'll give you guys some nuances. And some I'm probably going to share the same stuff that I talked about for depression, right? So, generalized anxiety disorder. I know this is a psychopharm class, but how do you diagnose someone with generalized anxiety disorder? I use a lot of mnemonics. So if you want, you can write down Watchers. Watchers, Watchers, right? So W stands for worry, A stands for anxious thoughts, T stands for tension, H stands for hyperarousal, E stands for energy, right? They might have low energy because they're always stressed. R stands for restlessness, and S stands for sleep, right? So those are the main symptoms that you would see in a DSM in a general sense, right? So they're worrying, they have muscle tension, you know, they might have hyperarousal, they might have low energy, they might have issues with sleep, right? And that needs to occur for at least 6 months for it to be diagnosable as general anxiety disorder, right? That makes sense. Now, I know this is not a diagnosis class, but just to understand what symptoms we're treating with the medications will give you a better understanding. All right? Questions so far? Am I going too fast? No. So whenever I start seeing patients, I have a bunch of like mnemonics that I have written down on a piece of paper. All right, just so you know, I have if I feel like a patient has generalized anxiety, I'll put watchers on the sheet, and every time they talk to me and they answer questions, I'll check off. All right, they're talking about worry, I check off the W from watchers, right? They're having issues with sleep, I check off the S. They say they have muscle tension on their back, on their neck, I'm gonna check off the T, right? I think I have ADHD, I can't focus in school. I check off the C, right? And based on how many of that criteria they meet for at least 6 months, you're pretty sure that it's a generalized anxiety disorder, right?
I'm sorry, what is C?
C is concentration.
Oh, concentration.
Concentration, right?
Thank you.
Now, if you look in the style book there's also some controversy between is general anxiety its own entity, right? Or is it just a subset of major depressive disorder, or is major depressive disorder just a subset of general anxiety disorder? The reason why is because a lot of the symptoms overlap, and it's just the core symptoms in the middle, right, that are very different. So for anxiety, it's worry, right? Constant worry and anxiety. And for depression, it's what? Anhedonia and low mood. And I'll give a nuance for child psychiatry. Irritability is criterion A for that. So the difference is that if a kid comes to you, like a teenager, you might not look for low mood, but they might have irritability, right? So that could be a criterion A for child psychiatry for depression because kids manifest it a little bit differently, all right? But a lot of those core other symptoms, changes in sleep, poor concentration, anergia, they kind of share the same symptoms. And when you treat, I mean, in the treatment is almost the same, right? That's another point that people make. And two, it's hard to find someone that just has MDD by itself that doesn't have anxiety, right? And it's hard someone to have GAD and doesn't have some depression. Have you ever seen that before? They kind of come hand in hand. Now, it's hard to know if someone has I'm going to go back to the classical sense now that they're two separate entities, right? I just brought up that the controversy because there are some practitioners that argue they're almost the same. Now we're going back to classical, which means they're two separate entities, right? It's hard to know if someone has MDD with anxious distress, right, which is a specified from DSM-5, versus someone who has MDD and GAD comorbid. Because sometimes if someone has MDD with anxious distress and you treat the depression, right, assuming that depression is the main cause and the anxiety is a manifestation of the depression, it gets better, right? But if it's MDD and GAD, two separate entities, sometimes you have to treat both, or else one doesn't get better. Does that make sense? But it's hard to know it. You can't really like do any tests or even some clinical questions. It's very hard because patients don't know. If you ask them, does it seem like the anxiety comes with the depression? I don't know. How am I supposed to know? Right? And they kind of give you the same timeline. They both come hand in hand. Does that make sense? So depending on how they respond in treatment, how they might answer your questions, if there's a family history, right? If there's a family history of anxiety, then maybe there's genetic loading there. You might assume that there could be separate entities, right? But there's a family history of all depression, and the patient. No, so yes, Madison.
So what if the patient doesn't have all but has most of the symptoms? What, like,
So that would be called a form thrust presentation, which we use a lot in psychiatry. So unofficially, a lot of people will say they don't do that, but they do that, and I do it also. Is that a patient sometimes might not give all the symptoms, right? But you have to diagnose them with something, or the appointment's not going to be billed, right? So you round up a little bit. You use your clinical intuition. So you seems like you have a little bit more depression. I'm going to give a provisional diagnosis of MDD, right? Ruling out bipolar depression, obviously, because that might come later on, and maybe a provisional diagnosis of GAD, right? Because you can always change it. Diagnosis could always change. Does that make sense?
Yes.
Okay. So now my intuition tells me that maybe the patient has MDD when anxious or stressed, right? So I'm going to go all in on the depression first. What would be my first option? What class of medications?
SSRI.
Very good. Selective serotonin reuptake inhibitors, right? Now, if it's an adult patient, a lot of times I'll either use Lexapro or sertraline, right? Or escitalopram, which is the same as Lexapro, or Zoloft. Sorry, I'm going to use brand names and generics interchangeably. But escitalopram is Lexapro if you don't know already, and sertraline is Zoloft. Right? Escitalopram, in a pretty recent meta-analysis, for whatever reason, showed more weight gain. So I tend not to use that as much anymore because I realized that a lot of patients gain a lot of weight on that. Sertraline tends to be a little bit better. Prozac probably has like the least amount of weight gain, but again, it also could be different with certain patient populations. If the patient was planning to breastfeed and get pregnant, what medicine would I lean towards that? And I mentioned this in depression. Sertraline or escitalopram?
Sertraline.
Sertraline, very good,
Sertraline.
right? Yeah. So it has a relatively less, it's called RID, relative infant dose is what we use, right? RID means that how much of the medicine is going to leak into the breast milk, right? I don't know the exact number, but it tends to be much lower for sertraline. That's why we use that a little bit more. You can actually go online, you can type RID, and it'll give you the RID of most of the psychiatric medications. And you could probably base risk with the patient based on that, right? Relative infant dose. If you do perinatal psychiatry, they look at that a lot. All right. So if it's a mother of childbearing age, they're saying that they want to get pregnant soon, sertraline might be the good first option, right? But let's say they've tried sertraline in the past and they didn't like it. Would it be fair to say, well, we could do Lexapro as an option? Yes or no? Yes, it would,
Yes.
of course.
Yes.
Yeah. Yeah. You just have to document that we offered sertraline, but the patient has tried that in the past and it just wasn't a good option for them. So you could definitely try Lexapro, right? Now, in general, I'm going to make a pretty blank statement, but in general, when you're treating depression, patients can respond at the lower end of the spectrum, right? So I'll use Lexapro as an example. Starting dose in pediatrics is usually 5 milligrams, right? Even though I'm not going to test you in starting doses, this is just to get you guys to understand a little bit. 10 milligrams usually is the starting dose for adults, right? Or adolescents. Sometimes for depression, people might respond in 5, but they might respond in 10. You can keep that for MDD and they'll be fine, right? But for anxiety, we tend to go a little bit higher. So usually 15 or 20 patients might need for anxiety, right? It tends to be a little bit higher for generalized anxiety. Same as sertraline. Sometimes for sertraline, 50 or 100 might be beneficial for MDD, but if someone has anxiety, we usually push it up to 150 or 200. No one really knows the exact reason why, but for some reason, we just need a little bit more serotonergic activity to help with the anxiety, right? Because anxiety, you know, is manifested through a hyperfiring amygdala sometimes, right? And sometimes the serotonin, when you increase serotonin, it has an inhibitory effect on the hyperfiring amygdala. So when you increase serotonin, the amygdala tends to calm down a little bit, right? Just a little bit. That's one way to kind of calm down anxiety, right? Increasing serotonin activity. Another way is using an SNRI. Why do you think an SNRI, why would increasing norepinephrine also help with anxiety? What do you think? What does it do?
It'll also help there be more dopamine in the prefrontal cortex, which can help with focus and like calm their mind down, help
Okay,
them.
good. Sometimes people call that top-down inhibition, right? There's bottom-up drives and there's top-down inhibition. We'll talk a little bit more about this concept when we talk about ADHD when it comes to impulsive behaviors, but our frontal lobe, right, is also going to have a inhibitory factor telling us, hey, Joseph, be careful because, you're driving too fast. You might get a ticket or you might crash your car, right? So a little bit that will kind of increase your judgment a little bit, right? Or if someone's very anxious, oh my God, I'm worried that these people don't like me, your frontal lobe might override it and say, why? Why are you thinking that way? There's nothing that, through psychotherapy or just through, reasoning, you can say, I haven't met these people yet. Why would they not like me, right? It doesn't make any sense. Why am I assuming they're going to hate me and I haven't met them yet, right? So that's called top-down inhibition. That's one way, tuning norepinephrine. Another way is that there's a connection from the raphe nuclei, right, which is one of the main cell bodies that secrete serotonin, and it connects to the amygdala, which has also, beta receptors on there and alpha receptors on there, right? Now, when you increase norepinephrine, it's going to bind to those norepinephrine receptors, right? The alpha and the beta receptors. What's going to happen initially, someone might have increased anxiety in the beginning, and we have to warn patients about that. If I'm going to give you an SNRI, right, you might feel a little bit increased anxiety. Even with actually SSRI, sometimes too, it can happen, right? You might have a little bit increased anxiety at first, but then once your receptors, they're going to what? Are they going to downregulate or they're going to upregulate if you're stimulating them with norepinephrine? They're going to what? Too much. They're going to downregulate, right? Are they going to be more sensitive or less sensitive? Less
Less
sensitive. Very
sensitive.
good. They goes hand in hand, right? Because you're increasing norepinephrine and that initial anxiety, yes, might go up a little bit and patients might not like it. Now, what I usually do, a strategy I use, right, is I give them something PRN for anxiety during those first couple of weeks while the SSRIs and SNRs are working, right? If someone's very anxious, I might even use a benzo short term, right? Like Ativan, Klonopin, or even Xanax if it's very short. But short term, I'll give them like a 2 week supply. What I'll do sometimes is because if you don't treat that initial anxiety, patients will never stay on the meds and treatment will always fail. So you need to have something to help them stay on the meds for it to work. And if there's no history of substance use, right? There's no history of falls, nothing that might, prohibit you from using, benzos or even Atarax, hydroxyzine if you have to, then it's not a bad option because then and they can take it when needed. And then eventually once the receptors accommodate to that, when they downregulate, they become desensitized, the patient will have relief, right? Does that make sense? So what I'll usually do is I'll use a benzo. I'll give them maybe a month supply. The second month, I'll give them a 2 week supply. Then the third month, I'll only give them 7 days. Then we stop it. That will be definitely ample time. Sometimes I don't even have to. Sometimes give them a month and then it goes away. But usually, I give them up to 3 months. And really, 3 months is when people develop dependence. If we're taking benzos consecutively for 3 months, it's usually when people have dependence on. It's very hard to get off. All right, usually. Of course, there's always going to be patients that have dependence earlier and some a little bit later, but on average, it's about 3 months. All right. Questions with that?
What
Yes.
what if they have superimposed PTSD? You can't give someone with PTSD a benzo because it's like bad for it. So do you first stabilize the PTSD and then treat the generalized anxiety, or like how do you think about that?
So the reason why I'll go back to this later on, but the reason why I'll just answer your question short. The reason why we don't give benzos during PTSD is because it doesn't allow them to fully absorb the therapy, right? Because sometimes we use exposure, re-exposure prevention in PTSD, right? We expose them to the traumatic event in a controlled environment, right? With the therapist there, giving them emotional and physical support, right? And if someone's cognition is dulled down with GABA, right, due to the benzo, they're not going to absorb that, and it's not going to they're not going to be able to get that. So in reality, we stay away from, and I'll tell you my strategies to help with PTSD patients in a few minutes when we talk about it. But GABA is not a good idea because they're not going to be absorbing. In general, giving someone a benzo before psychotherapy is not a good idea because they don't have their full faculties to absorb whatever the therapist is telling them, right? That's why we and also PTSD and war veterans, a lot of PTSD is comorbid with substance use disorder. You don't want to give someone benzo who has PTSD from, I don't know, the Iraqi war or Vietnam or something, because there's a higher likelihood they're probably drinking alcohol, using substances, and it's not gonna, be beneficial for them. Does that make sense?
Yeah, but if they are mid PTSD treatment and they come to you complaining of anxiety symptoms, do you wait for the PTSD treatment to be over before you say, all right, let's try an SSRI, and then
It
you go from there?
depends.
Or depends.
Yes.
Okay.
Normally, yes. Normally, yes. Because
Okay.
based on which I talk about this in 517, but I might not be teaching 517, so I guess I'll give you guys a sneak peek of what I teach. It's called diagnostic hierarchy. You always want to treat the top, the diagnosis that has more symptoms, right? Let's say if someone comes to the ER and they have a cough, right? You want to rule out the most dangerous stuff first, pneumonia, right? And they have a fever. Once you rule out the most dangerous stuff that could kill them, then you can figure out, is it allergies? Is it something else? So substance use should be number one, right? Are they using cocaine? Are they using downers that makes them seem depressed? Two, is there PTSD? Because chronic PTSD can look like anything, right? Three, is there an underlying mood disorder? Because mood disorders can look like schizophrenia, right? Someone can be psychotic and be manic, right? Four, are they having a psychotic episode, right? Five, do they have anxiety? Six, is it ADHD, right? ADHD is always last because if you give a stimulant at first to treat the ADHD, you can worsen the anxiety, you can cause psychosis, you can cause mania, right? So notice how if you follow it in the step-by-step approach, when patients come to you with multiple complaints, you can treat them without destabilizing other stuff, right? But a little advanced for this class, but yeah.
Is it just usually no benzos with PTSD, or is it like SSRIs, SNRIs?
In general, I would say no for now, but I think there might be some circumstances where you might make an exception because there's always going to be exceptions in psychiatry. Or there's never really black and white, as you learn. But in general, I would say probably majority would be no. But there might be a circumstance in which you might need to use it, right? What about someone who has PTSD and has catatonia? What do you talk about catatonia? Or someone who has PTSD and chronic panic attacks, panic disorder, and they can't, those panic disorders are constantly nonstop. They can't even leave their house. I guess at that point, in order to get them to go to the PTSD clinic, I have to give them a benzo, right? To get them out of their house. So
But what about SSRIs and SNRIs? Or is it just benzos?
no, we use SSRIs and SNRIs for PTSD also. There's quite a
Okay.
few that are FDA approved also. We do, yeah. But we'll talk about PTSD after we finish GAD. All right. So GAD in general, right? SSRIs, SNRIs are going to be the mainline treatment there, right? Sometimes people do use Lyrica, and sometimes people do use gabapentin off-label. All right. So you might see that if you're, in inpatient psych or outpatient. You might see that because there might be some patients that don't respond to SSRIs or SNRIs, but those would be like third line or even fourth line. I've been using pregabalin more now, and it's just because of the population that I work with. So I'll give you an example, right? One of the students I'm precepting, because I do precept students occasionally, he was telling me that he was talking to an inpatient psychiatrist, and he was mentioning what I was telling him. And the guy was like, no, no, it doesn't make any sense. I said, sure, it doesn't make sense in inpatient psych. And if I worked in inpatient psych, I'll probably have that same view as that doctor, right? But if you work outpatient, it's a very different atmosphere. You have more meds because in inpatient, it's only formulary meds, right? It's very hard to get the branded meds. And it's also the population. An outpatient is more likely of me seeing patients that are first episode, right? So I could get away with using these meds first. Once someone's inpatient, they're usually in the hospital system for such a long time, they're a little bit more chronic. So those recommendations I'm giving might not make sense for those patients. So it's also based on the population, right? Now, where I'm working now, I work in chronic treatment-resistant depression, treatment depression anxiety, treatment depression OCD, right? So I'm going to see patients that are not first line. So these patients have already tried SSRIs, SNRIs. So it's my job to probably use polypharmacy, right? Or think outside the box and use other meds to get them better that other providers either weren't comfortable doing or they didn't use with them, right? So I use pregabalin, you know, but it's a controlled substance, right? I make sure that the patient is not abusing any other substances and I monitor them. So I do use, pregabalin. The funny thing is pregabalin and gabapentin are very similar, but one is a controlled substance, right? Pregabalin, Lyrica is used for pain medicine also, and it's controlled. And gabapentin, anyone can prescribe, and people sometimes can abuse it also. So just so you guys know, the difference with that, with pregabalin and gabapentin, it works on a calcium channel called alpha 2 delta ligand, right? It's an accessory to the channel, similar to like GABA A receptors. It's a subunit of it. And what it does in theory is that, in the action potential, you have sodium channels opening, right? And it goes down that cascade. And that last channel is going to be a calcium channel, and that calcium efflux is going to cause the vesicle to release a neurotransmitter. So by stopping that calcium channel at the very end of that cascade, you're going to stop the release of, glutamate, right? So it's a glutamate neurotransmitter, and you're going to stop the, seizure or the anxiety symptoms, right? Now, there's a lot of relationship between seizures and mood disorders and anxiety. So there was actually a psychiatrist called Robert Post that figured out, he had this hypothesis that maybe kindling, which means that if someone has a seizure, they're more prone to having other seizures. Maybe that concept is also similar to mood disorders, right? Because we do see that if patients have, one depressive episode, they're more likely to have more depressive episodes. So if someone has one panic attack, they're more likely to have more panic attacks, right? So with that logic, he tested on rats. He tested Depakote, valproic acid on rats, and he realized that the rats didn't have as many seizures. And then when he tested it on humans, the humans did not have many episodes, right? And at that time, the only really other med that we had for mood disorder was lithium. So we needed an alternative for it. So Depakote got that indication for, bipolar disorder at that time. The funny thing is that they've tried other meds for seizures, for mood disorders, and they didn't really work out, like Keppra, topiramate, gabapentin. They tried that. There's the mechanisms are similar, but for whatever reason, the trials never panned out. And even, I've tried them too off-label and didn't work for patients. So, you know, that's why sometimes, textbooks and theory don't always relate to clinical practice, right? Now, going back to anxiety, if you give someone gabapentin or you give someone Lyrica and you stop that calcium from going to the cell, you're going to stop the excitatory release of glutamate and you're going to calm the person down, right? In essence. So the two ways, you can work on alpha 2 delta ligand, stop that calcium channel. You can give someone a GABAergic medication like a benzodiazepine, right? That will be last, but it works. They're very effective, right? You can use an SSRI, SNRI. An SSRI will help calm down the amygdala, right? The SNRI might help, like Joseph said, help with fine-tuning the frontal lobe, working with top-down inhibition, and also help down-regulate your norepinephrine receptors, the beta and alpha receptors at the, amygdala, which is being innervated by the Raphe nuclei, right? Does that make sense? So those are
Um,
just different ways that we can downregulate anxiety. Yes.
that does make sense. I just wanted to ask, the Lyrica and the gabapentin for anxiety is off-label, so that wouldn't be something we would
They
talk
would be
about, like,
off label, correct. Yeah.
okay.
Just for your information to know. Yeah.
Okay, thank you.
Right. So if we try the on-label meds, we would try the SSRI meds first, right? And then we would try the SNRI meds. If someone had anxiety and happened to have chronic back pain, what medicine might you lean towards? Same as depression.
SNRIs.
SNRIs, right? Because norepinephrine has a down-regulating effect on the spinal cord, so it might help with their pain also. So I did a consult today for a primary care doctor, and the patient had chronic back pain, and the patient was like, my Zoloft is not working anymore. And the doctor was like, what would you recommend as a second line? So he has chronic back pain, so I was like, why don't we just try duloxetine, right? So my recommendation was switch the patient to duloxetine. So we'll see. That might be a good option for them. If there's no, this is just the way, I mean, there's also the art of psychiatry. Everyone practices differently. So I don't expect you guys to practice the same way I do it. But the way I look at it is I don't like using SNRIs unless there's migraines, chronic pain, or really bad, like low energy, right? Getting out of bed. But even then, I'll probably use Wellbutrin first, unless I'm worried of like seizure risk if they drink a lot of alcohol. That's just the way I look at it because I've had, patients have a hard time getting off of SNRIs. And also the sexual side effects of SNRIs are pretty much the same as SSRIs. So if I'm treating like a young adult, I don't want to put them through that misery of going on a med that's going to kill their libido or their sex drive. So I usually go on Wellbutrin, but if there's pain, then I'll use an SNRI. All right. Does that make sense? Okay. Now, besides the SSRIs and SNRIs, we have the 5-HT1A partial agonists, right? And there is only one 5-HT1A partial agonist that's FDA approved for GAD. What is that? Buspirone, right? So we can use buspirone. And in inpatient, we used to dose it TID, but I realized that in outpatient, that's not really practical. So I dose it BID for patients usually. If someone wants to take a TID, I prescribe a TID also. But usually I'll say, let's do twice a day first. Because most of the time, they'll need coverage during the daytime anyway, right? During the morning and afternoon. So if you dose it after breakfast and after lunch, that usually covers it for most of the day. Unless they work like a second job and then they leave at like 11, they work a nursing shift, 12-hour shift or something, and you need more coverage, then maybe TID dosing might not be a bad idea. Right. The only thing about Buspar that I warn patients about is that it's a 3A4 substrate. And it has, since it's 3A4 substrate, there's a lot of 3A4 inhibitors, right? Like marijuana, like chamomile tea, like what? What's another one? Marijuana, chamomile tea, grapefruit juice, right? Like antifungal meds. For those athletes out there that keep getting jock itch, they might be on fluconazole, right? That's going to affect their medications.
Fluvoxamine.
Fluvoxamine also, yeah, but it's a 1A2 inhibitor, so unless it's 1A2, it wouldn't affect what do you call it? Buspar. But yes, it's good that is an inhibitor. That's why sometimes it's good to know exactly what enzymes it inhibits because it might affect specific meds but not others. All right. I try to make it practical. I mean, there's a lot of inhibitors out there. Ciprofloxacin is also a very potent inhibitor, but you don't really see that much. And the thing is, it's not significant because people are on Cipro only for a week or so, right? For UTI. It's not going to be long term. So the interactions are not going to be that significant, right? Whenever a med is metabolized by one CYP enzyme, there's more risk of people having toxicity from it. Does that make sense? Because there's only one pathway of it being broken down. Unlike, meds that have multiple pathways. I'll give you an example. Alpha 2 agonists, right? There's clonidine, there's guanfacine. I like to use clonidine more because it tends to sedate people and it calms them down. And sometimes you need that at night, especially if they have ADHD and they can't sleep at night because of the symptoms. It calms them down. And clonidine is broken down by multiple CYP enzymes and also phase 2 metabolism, which is not CYP, but we'll talk about that another time. Guanfacine, which is also an alpha 2 is only metabolized by 3A4. There's a high likelihood that they might take an inhibitor and they might have a side effect from it. So in general, if I can get away from it, I will try to prescribe a med that has multiple pathways of breaking down. Because if it's only broken down by one pathway, there's going to be more risk of drug-drug interactions. Does that make sense? Okay. So the meds that have more have more drug-drug interactions are just one pathway usually. All right. Buspar. When I first started working outpatient, I didn't really use Buspar a lot because I thought it was a bullshit med. I just thought it was placebo, honestly. But then I had a colleague that was using it with a lot of his patients, and they were doing real well on it. So I started prescribing it more, and I realized that it does have benefit for patients. One, as a monotherapy for GAD, if someone can't tolerate SSRIs because it doesn't have sexual side effects, as long as they can tolerate BID dosing, right? And two, if someone was trying to get off of benzos, it could be a fair option to get off. Believe it or not, Buspar was created by the farm company as a way to get off benzos. It was supposed to be a safe alternative to it. So Buspar stands for abuse sparing. If you're ever on Jeopardy and they ask you what does Buspar mean, the idea of Buspar was abuse sparing. Buspar, right? Useless psych knowledge, but it's good to know. So that means you can technically, if someone was on Xanax and you wanted to bridge them off and needed a safer alternative, and and hydroxyzine makes them too sedated, you technically could try a 5-HT1A partial agonist like Buspar and bridge them. All right. Max dose of Buspar is actually 60 milligrams a day. I've noticed sometimes some providers will say, I don't like Buspar, it doesn't work. And some patients will say, I don't like Buspar either. I tried it, it didn't work. I'll ask them, what was the highest you've gone? They'll say, well, 5 milligrams twice a day, or even 10 milligrams twice a day. I'll say, did you have side effects? No. All right, we're going to try to push it up to 30 milligrams BID, which is 60 milligrams a day, which is the FDA approved dose for it. There are some patients that will need that. All right. So if a patient tells you they've tried a med and it didn't work, always ask, one, how long did you take it for? And two, what was the max dose that you've been on it? Because many times patients will say they've tried many meds and it was a failed trial, but when you actually write it down, either they didn't take it long enough or the provider didn't escalate the dose high. Like I said, for anxiety, you tend to go higher, right? So if someone says, I've already tried the SSRIs for anxiety, it didn't work for me. All right, tell me what you tried. Try Lexapro, try Prozac, and try Zoloft. All right, tell me how long you've taken it and how high did you go? Well, Lexapro I only went to 20. Prozac I only went to 100. Lexapro I only went to 10. Then those weren't really adequate trials for depression. I mean, for anxiety, I'm sorry. Those are adequate trials for depression only. So I would probably say, can we try it again? Because I don't want to escalate and put you on pregabalin, and then you really need to be on that, right? I don't want to put you on polypharmacy, and unless you really need to be on that, right? So always try to retrial meds again. In my private practice, when a patient comes to me, I give them a sheet of paper that has pretty much all the regular meds on there. You tell me what diagnosis you've had, and on that diagnosis, it'll give all the meds there. If you say GAD, sertraline, Prozac, Paxil, all the meds that are FDA approved. And if you've taken it, you hit the checkbox, and I ask you, how long did you take it for? And what was the highest dose you've gone on? Right? So if I look at it and I say, hey, we can try that again because that was an adequate trial. Unless they're totally against it for whatever reason, of course, I'm not going to force them. But it's always worth a trial because patients don't know any better, right? And they've been on multiple meds without actually trying it. I've had patients also, I don't like Zoloft. Gave me really bad diarrhea that one time I took it. That one time you took it, what happened? Tell me. Did you order food? Like, actually, yeah, I did. I ordered Chinese food that day, or I ordered something and I got really bad diarrhea. So is it possible it was the food you ordered? Are you willing to give it a try again? Yeah, if you think so, sure, give it a try again. And they actually did very good on it. So before you disqualify a patient from saying they've tried multiple meds, always ask when they started it, how long they were on it, and what was the highest dose they've been on it. All right. And if a patient says, well, I tried, like this is going to be a very good clinical case for you guys. Someone said, I've been on Lexapro, I've been on Celexa, and I've been on Zoloft. I've been on Celexa 20, I've been on Lexapro 10, and I've been on sertraline 50. And they gave me really bad side effects. Bad diarrhea, bad nausea, made me really anxious, affected my sleep. What do you think they are? You think they're poor metabolizers or fast metabolizers of which enzymes?
Fast metabolizers.
Fast? You sure? No. Not fast. They would be
Oh,
slow.
they had side effects
That
or
side of, yeah. So they will be
more
slow
metabolized.
metabolizers, right? Of 2C, what? 2C19. They share that same pathway. So Lexapro, Celexa, and Zoloft share 2C19. Now, I don't expect you guys to memorize that right away, but imagine if a patient comes to you, right, and they say that, and you tell them within 5 seconds, oh, easy. I think you just a slow metabolizer 2C19. Maybe you should try fluoxetine. Why? It's a different pathway. We could push it up, and it works for them. How do you think that's going to make the patient feel about your competence, right, and your connection with them? That's going to increase therapeutic relation very fast, right? Imagine you went to an office and someone figured out exactly what was wrong and they got you in the right treatment right away. So those patients where I was able to figure that, I call it the aha moment, right? Within less than 5 minutes meeting with them, I was able to figure out there's a drug-drug interaction there. Stop that, or let's increase that, and I think you'll be fine. Come back in a week or 2 weeks, and they feel better, right? That patient engagement is going to be great. They're going to stay with you forever, all right? So you want to have as many aha moments with patients early on in treatment, especially in the beginning. When you first meet a patient, they're like, "This is Joseph competent, right? Or does Joseph like me, right?" Those are two important things. Number one, and they kind of go hand in hand. I don't care if Joseph likes me if he's not competent, right? And I don't care if Joseph's competent if he doesn't like me. You have to have both. So if you have both, then you're gonna have a patient for life. So that's just the art of psychiatry. Now, SNRIs. Someone's on it, it's working, they have chronic pain, you're giving them for depression. Check liver enzymes, all right? Because there could be spontaneous liver injury with those patients. So same warning as if they have depression. Questions? No? Okay. If someone has situational or performance anxiety, and they just say, "Hey, I'm having, I have a lot of, I sweat a lot. Sometimes I shake. I feel like my heart rate is going up, and it only happens when I'm having like presentations or when I go on first dates." I would probably recommend a beta blocker for those patients. All right, like propranolol. So that would be the option you could use for those patients. If it's just situational anxiety and it's not like a general anxiety that's always persistent, I normally wouldn't recommend an SSRI long term for that. Because what are the risk benefits, right? Sexual side effects, weight gain, apathy, right? I don't think it's worth that. So those patients, I probably would put them on that. Or if they're one of the few patients that don't get sedated too much with hydroxyzine, which is an antihistamine, that might be a good option for those patients too, right? I'm flying. I'm just afraid of flights. I'm only going to be on the flight for 1 hour or 2 hours. Sometimes Xanax might be appropriate for those patients, right? Short term, just give them two for their flight, going there and going back, or a beta blocker, right? Does that make sense? Good. Like going back to PTSD, right? PTSD, in my experience, is not effectively treated just by pharmacology, right? So if I tell a patient, hey, you have PTSD, you can't just come to me and get meds every day and resolve the issue, right? It's like a band-aid. It's not really going to help you because in reality, you need to really, process. Processing is making sense of your traumas, right? So sometimes, right, there's many different hypotheses of why, trauma happens, but, a lot of times our brains are working in contralateral sense, right? The left and right are working together. So obviously the right sense of our brain, the right side of our brain, the right hemisphere is innervating the left side and the left side is innervating the right side, right? Depending if you're lefty or righty, one side may be more emotional, one side may be more, uh, cognitive, right? When you think things through. And sometimes when traumas happen, only one side of your brain is activated at that time, right? So one of the hypotheses is that if one side of your brain is activated, when you have a trauma response, your brain kind of goes through a shutdown mode and it can't make sense of what you're feeling. So for instance, if a patient was like touched inappropriately by a family member, right? And something reminds them of that, they don't know what to feel, their body shuts down. It can manifest very extreme also, like dissociation, where they might sometimes lose their vision, lose their hearing, lose the ability to walk. I've treated patients like that too, right? It was very bad trauma because there's a disconnect between the left side and the right side of the brain. Some of the treatments for that, if there's a disconnect, would be EMDR, right? Which is called eye movement desensitization resensitization therapy, right? Eye movement resensitization sensitization. Um, Now, what the therapist is doing is they're going to do a they're going to do a narrative with the patient, right? Obviously, it's going to take many treatments, and they're going to first, before you even start doing that stuff, you have to make sure the patient is safe, and there might even be like one or two treatments in which you're just establishing rapport with the patient, trying to develop that relationship with them. But once you start doing the processing, in essence, once they're narrating the traumatic event that happened, they're either going to be touching left side, right side, right, activating the left side or the right side of the brain, right? That's one way. Or looking at a, image going left and right? Or looking at a pocket clock, whichever one they use, right? But innervating one side is actually when you touch the left side, you're innervating the right side of your brain. Right? When you touch the right side, you're innervating the left side of your brain. So while you're talking through that narrative, you're activating both sides of your brain. It's kind of realigning what should have happened in the first place, and then it helps you kind of make sense of what happened, right? Sometimes they might also have, we talk about this term in psychosis, but it's called alexithymia. Alexithymia means that the person can't put words with what they're feeling. So I'm feeling anxious, but I can't put words to it, so my body manifests that by I can't walk or I fall down or I have muscle weakness, right? Or I have a seizure. I'm sure you've seen that before, right? Non-epileptic pseudo seizures, right? Non-epileptogenic, whatever that's called, NPSEG seizures, right? Now, the patients don't want to fake it, right? It's outside of their control. They're being activated by some event and their body responds that way. So a patient doesn't want to do it intentionally. So, don't tell the patient, hey, you're malingering, you're faking it, because they might not be doing it. So, you don't want to say that to a patient. But it feels real for them. So we have to treat it, right? So when I treat PTSD, I usually tell patients, look, if you think that I'm just going to prescribe you meds to treat your PTSD, I'm going to refer you to one of my other colleagues because unfortunately I don't have time to do psychotherapy with them. And it takes a lot of psychotherapy. And in reality, they probably need a separate therapist because they're going to have more intense therapy together with the psychiatric medications, right? So you kind of have to work together with the therapist and the patient to find the right doses of meds. The key is medicating the patient enough that they can still feel a little bit of distress from their therapy, right? But not enough that they dissociate and they go into the seizure in therapy or they manifest it in other ways that they do, right? So you kind of have to find that balance. So sometimes what happens is the patient starts doing, trauma therapy and they get a little bit worse. And I might have to escalate the dose a little bit of the meds at that time. Then as they get better, they develop a better rapport with the therapist and their symptoms get a little bit better, then I start reducing the dose. But it's an active process. So you need to really, partner. So in reality, you should partner with a therapist and have a HIPAA consent form so that you guys can kind of discuss the case. When I was working outpatient, it was easier for me because the therapists were in-house, like their office was right next to mine. So after the session, I can walk over and say, hey, what's going on? What do you think? And I'll even tell them, I'm going to adjust this medication. Let me know. Because sometimes what happens too is patients with PTSD, they're going to have nightmares, right? So PTSD, I love mnemonic, trauma, 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 Trauma. What do you think T stands for? Trauma. They experienced something that was distressing, right? R stands for they're re-experiencing it. So they might be having flashbacks. Even though it's not happening anymore, they're leaving their house and they're re-experiencing that trauma, right? A stands for avoidance. They avoid situations that might cause those symptoms, right? They avoid walking the street a certain way. They avoid social gatherings. They avoid certain things, right? They avoid going to the bank, whatever it is. There's avoidance behavior, right? U stands for unrelenting, right? It's unrelenting. It's affecting everything in their life, right? It's unrelenting, right? M starts for at least a month, right? And A stands for high anxiety state. Right, so that's how I remember the signs and symptoms of PTSD. Trauma is the mnemonic that I use. Right, a traumatic event that's that patient is having avoidance, it's unrelenting, it's happening for at least a month, right? And there's high anxiety state. Questions, thoughts? All right. So if someone has PTSD, you're gonna have to also treat the flashbacks and the nightmares, right? Now, this is off-label, but I might test you on this only because we don't really have good SSRIs to help with this, right? Prazosin, an alpha blocker. I use it a lot, and a lot of PTSD specialists use it also, and it's been life-saving for a lot of my patients. It's so important that I'm willing to test you on it, even though it's off-label, because you need to learn how to use it with patients.
How do you spell that?
Prazosin, P as in Paul, R, A, Z as in zebra, O, S, I, N, prazosin, or prazosin. People call it both ways, right? It's an alpha blocker. And what it does is it blocks those receptors once again on the amygdala, right? That's being innervated by the raphe nuclei so that you're not having a fight or flight response, right? If you're having a fight or flight response in the middle of the night while you're trying to sleep, you're gonna have nightmares, right? Or very distressing dreams, or night terrors. If you're having it during the daytime when you're going to the bank or you're, at the mall, you're gonna have flashbacks, right? Which are indistinguishable from it happening. So people are re-experiencing stuff almost like they're there in the moment, right? People who have flashbacks will say, I felt like I was there. I felt like I was re-exposed again. I felt like, war veterans. I felt like someone was throwing a grenade at me and I had to jump behind the bench, right? I felt like the dog was gonna bite me the same way it bit me when I was, 5 years old. That's why I'm afraid of dogs. So the key is, you know, helping them kind of make sense that this is not happening anymore, right? This happened in the past. This is not something that's happening now because your brain is kind of fixated on it. One way to help with that is helping with the norepinephrine fight or flight response by using prazosin, right? So what I do sometimes, I give them maintenance dose of Zoloft, sertraline, which does kind of help with the anxiety in general, but I also give them prazosin or prazosin at night to help with the nightmares. Because if you don't help the nightmares, they're not going to get good sleep. They're going to be unrested when they go to the therapy for the PTSD, and they're not going to function. So you have to treat the nightmares, all right? If prazosin or prazosin doesn't work, you can also use trazodone. There's some evidence also that trazodone helps for nightmares as well, right? It's also an alpha blocker. So you can, yes, question.
Just real quick, did you so you know how in depression we talked about our SSRIs are usually given in conjunction with something else because they kind of cause side effects. Is it the same story with treating anxiety, like or PTSD or whatever? Does it usually not do the job alone because it's such a general type of medication? SSRIs?
Yeah, sometimes you might have to adjunct. It's very hard sometimes with monotherapy, but I'll try my best to do one med first. But I always frame it that if one med doesn't work, I want you to be open to two meds. Because remember, I want you, guys, I want you guys to repeat this out to you. It's very important. We do not combine medications, right? Say it with me. We do not combine medications.
We
We do
do
not
not
combine
combine
medications.
medications.
We combine mechanisms of action. We combine mechanisms of action. Always, we do not combine medications. We combine mechanisms of action, right? I'm not combining two antidepressants. I'm not combining, an SSRI and an antidepressant, trazodone. I'm combining a serotonin reuptake inhibitor, and I'm combining an alpha blocker, an alpha 2 antagonist, right, and a 5-HT2A antagonist. I mean, an alpha blocker, an alpha 1 antagonist, and a 5-HT2A antagonist, right? Look at it that way. Because if you look at it that way, whenever you see patients come to you with medications, you're not just looking at the meds as a class, you're looking at the meds as their mechanisms, right? When I see trazodone, I don't see an antidepressant. I see a serotonin reuptake inhibitor. I had doses. I see a 5-HT2A antagonist, right? I see an alpha blocker, right? I see all the other mechanisms of that. When I see Prozac, I don't just see a serotonin reuptake inhibitor, right? I see a serotonin reuptake inhibitor with a mild norepinephrine reuptake inhibitor, right? All the other problem, the 5-HT2C antagonist, right? All the other mechanisms of action that distinguishes from other meds. So if you look at it that way, it'll make more sense to you. And just start looking at it that way now. So it gets easier as you guys, progress through, through the program. All right. I'm gonna answer Thomas's question because he has a good point. Yes, I do use beta blockers. Now, the concept of adding a beta blocker is that sometimes what happens when you have a traumatic event. Now, I know I wasn't going to talk about, pathophysiology and the brain, but I have to talk about it when it comes to PTSD because you have to make sense of it, right? When we experience stuff, right, it consolidates into our brain. So I'll use that example of, I won't use the uncle touching because that's too stereotypical. The dog bites you, right? It consolidates into your brain somewhere. And then what happens is every time you experience that, it reconsolidates again. Now, reconsolidation is important because the concept of reconsolidation means that it can either reconsolidate in a lesser form, right? And it's not as intense, or reconsolidate into a more extreme form, right? I'll give you an example of reconsolidation gone wrong, right? You have a nurse that's pretty amateurish, right? Working in the psych ER because they're covering, and they ask a patient, have you ever been sexually abused, right? And the patient says yes. That's all you need to ask for. That's it. But they think they're helping the patient. Can you tell me about that moment? Can you tell me more details about it, right? And now the patient starts dissociating and they're talking about it. And the nurse gets called, and oh, I got to go now. I'm sorry. Someone's going to take over. And then someone comes. Now the patient doesn't feel validated, right? And it just reopened the can of worms. So now the patient is going to reconsolidate that into even more stressful environment, right? Another example, you're interviewing an adolescent patient, right, who had a trauma for whatever reason, like they were abused by somebody, and they tell their parent, and the parent's like, no, no, that's impossible. That can't happen. I don't think that happened. You're lying, right? That's going to reconsolidate even worse now, because not only are they re-experiencing that again, they're losing that validation from a loved one, right? Their parent. So it gets even a lot worse. So that's a good point because unless you're ready to unpack the trauma with a patient, do not ask them for details about their trauma. All right? Do not do it. Because unless you're ready in the right frame of mind and you provide that psychological safety, that physical safety, and you have time for an hour, if you have to sit down and listen to them, you don't want to make it like quickly. I'm sorry, because they start talking. We can we skip that? And it's not right for the patient, and it's not right for you to even start that with the patient. All right, because it can be worse. Going back to Thomas's question about the beta blocker, when you reconsolidate, it also encodes your body's fight or flight response. So, for instance, when I'm talking about that, that traumatic event, my heart rate's going to go to 160, right? My blood pressure is going to go to 140 over 100. My baseline is usually 90 over 60. My heart rate's usually 55, right? But every time I talk about that, my fight or flight response is going to kick up, so my heart rate and blood pressure go up automatically. So therefore, when your body feels that, your mind is going to feel that same thing, right? Because the mind-body connection kind of goes hand in hand. If you give someone a beta blocker, right, there is some evidence that when they reconsolidate it with a trained therapist, right, to talk it through, what happens also is that they trick the body because when you're provided safety and you have a beta blocker, your heart rate can't go up as high, your blood pressure can't go up as high, right? Because physiologically you have beta blockers on board. So if it reconsolidates with a heart rate that's lower, a blood pressure that's lower, will it reconsolidate as less severe or more severe? What do you think? Less severe,
Less severe.
less severe, right? Because it's going to encode that fight or flight response much less. So yes, I also do that sometimes with patients. Yeah. Obviously, as long as they don't have asthma or COPD or any kind of, heart block or anything like that. So yes, that's another strategy I use also. So beta blockers could be a good option. SSRIs, right? Prazosin, trazodone for nightmares if you need it. All right. Questions, thoughts?
But to sum up the beta blocker thing, so it sounds like you give it to them kind of in the beginning of treatment to get them to like prime them to be able to go to therapy so they can participate. Is that right?
You can. So during the interview process, I'll usually ask patients, how does your anxiety manifest with you? Right? You tell me. If it's a lot of like somatic symptoms, like shaking, sweat, feel like the heart is racing, they can't breathe, right? Because the heart rate's going too fast, and yes, maybe a beta blocker might be a good option for that patient.
Hmm.
Based on what they respond. Yeah. What metabolizes the beta blocker? CYP what?
D6.
2D6, very good. 2D6. So what if you put them on Prozac and a beta blocker? Would that be possible? Yes or no?
Yes, but it
You
will
would be. You just
increase.
have to adjust. Very good. Yeah, you just have to adjust the beta blocker accordingly, right? You can do that. Remember, Prozac is a 2D6 inhibitor. So
How do you do these like adjustments? Is there like a table to follow, or you just generally go half if you're
I
going to
just
use
go
like an
half. Yeah,
inhibitor?
yeah. It's like cooking. You
Yeah.
just add a little bit of salt, you add a little bit of pepper. Go by. You can't really, it's hard to tell because you also don't know the genetic factors, right? Someone could be on an inhibitor, but themselves could be a fast metabolizer. Someone could be a slow metabolizer and be on an inducer. So it's hard to tell. But in general, I just cut it in half. I just cut it in half. All right. Questions. Now, benzos. We'll talk about benzos now. So I do use benzos, liberally, actually, surprisingly enough, I do use them, but I use them smart. So there are some patients that I do treat, 'cause I do treat severe patients. So with patients who have catatonia, who have panic disorder, sometimes chronic benzo use might be the only option for them. Because when you try to, but you should document that you've tried to taper them off the benzos before you keep them on it long term. All right. I'll touch on catatonia, even though I'm going to go into more detail when we talk about schizophrenia about this. If you don't know what catatonia is, it's a state of sometimes there's catatonia when someone's like frozen, like a statue, right? And there's stuporous catatonia, and there's excited. Yes, Elizabeth, question.
You can finish talking. I just have a question about benzos and catatonia, but
Yeah,
I
go
maybe
ahead.
not.
Sure.
Okay.
Okay.
So I've always wondered this because I saw a lot of it when I was working on in a Jerry psych unit, and there was a lot. We got a lot of patients with catatonia, and they were put on. I mean, even the younger patients. I saw one patient on like 5 milligrams of Ativan. Like it was just like round the clock
Yeah,
benzos.
yeah,
I
yeah.
always wondered like what happens long term to these people, because like you just keep them on it indefinitely, I mean, for their entire lives, like what, and then they leave the hospital, and like do they go into withdrawal if they don't have access to, I mean, obviously they will.
Yeah.
um I don't know. It just really struck me as like very, very hard to maintain that. So I was just curious what your thoughts were about that.
Sure. Yeah. So right now I have two patients that are stable with me, and they're adults now. I was treating them as kids when they were first episode psychosis, and they had catatonia together. They're on Ativan. They've been on it when I started treating. They were 16. They're in their 20s now. Over 5 years. Yeah. So I have someone on 10 milligrams of Ativan, 10 milligrams. I've tried to reduce it, and they start having the symptoms, slow movement. They stop eating. They stop talking. So I keep it to the point that every time they go to a new pharmacy, the pharmacist refuses to fill it, and I have to call them and explain the situation to them. They say, "Why is this patient in such a high dose?" I'm like, listen, the patient has catatonia. Do you want the chart notes? I'll explain. Once usually I say catatonia, they're okay with it. Now, to answer your question, Elizabeth, no one really knows the exact pathophysiology of catatonia, but for some reason, GABAergic medications help with it for whatever reason. If GABAergic medications don't work with it, we usually do ECT, electroconvulsive therapies. Those really are the main treatments. There are some trials that show that NMDA antagonists like memantine that we use for Alzheimer's might also help with it, but I'm not really sure if how effective that is 'cause I've never used it myself. But ECT and lorazepam challenge usually are the two main standards that we use. All right. Now the thing about catatonia is that yes, sometimes it is permanent and we don't really know why. So if someone has catatonia, we do have to keep them on long-term benzos until a better option starts. You know. I will I will tell you I had a patient, first episode psychosis that so I was treating him. I'm trying to change some stuff just in case he listens to this, but it was an Asian patient and the sister was actually a resident, a psychiatry resident, believe it or not. But she wasn't home. She was doing residency in another state. And her sister developed first episode psychosis, which is very rare. Imagine young female, right? Because usually they get it a little bit later. Age 15 developed symptoms of schizophrenia, had catatonic schizophrenia, was on high dose olanzapine just to help get rid of the psychosis, and had to be on Ativan at the same time for catatonia. I know we're not supposed to combine Ativan and olanzapine. There's a risk there, but she was on it in the hospital. It was the only combination that worked for her. So be aware that sometimes if IM it, there might be some pharmacies that won't fill that because there's a risk of orthostasis and the patient could fall. But the patient was responding to that, so we have it all documented. But the point is that the sister was like, um, why is my sister on, why is my sister on such a high dose of Ativan? And told the mom that Ativan could make her sister an addict and all this stuff. So the mom was like, my sister is a psychiatric resident. So I'm like, listen, like your daughter like wasn't eating, like she wasn't drinking. I'm like, before she got hospitalized, the hospital tried to lower the catatonia dose based on the notes that I'm saying, the Ativan dose, and she stopped eating and she lost weight. And they put her back on it, and now I'm taking care of her. So I don't feel comfortable reducing it, right? So the mom herself started reducing the dose. And the daughter was walking from school and froze in the middle of, I'm not even lying to you, was crossing the street and stopped in the middle, almost got hit by a car. Her
Wow,
movement
that is
started getting slower and
amazing.
slower. So catatonia, it can escalate very quickly. So the mom gave it to her again, got her to swallow it. She started doing better. But the mom again was like, I found another psychiatrist that tells me that my daughter doesn't have to be on Ativan lifelong. I'm like, listen, if that's what you think, I mean, I respect that. I mean, this is my opinion. I haven't heard from her after that, but we transferred her to another psychiatrist. But
So do they just, there's no what, like, you would just keep them on it for life?
yes, yes, right now. But again, this is 2026, February 27th. What I'm telling you now is what the evidence is for this time. It could change 6 months from now, it could change a year from now,
But
right?
like,
That
in
must,
terms of
oh,
tolerance, what happens to the
Not
dose?
necessarily for whatever reason with catatonia, because you're not using it for anxiety. You're just using it to make sure that they're functioning, that they're moving, their muscle movement is normal, right? That they're talking and that they're eating. They usually don't build a tolerance to that, unlike, other stuff. Yeah.
does it reduce life expectancy if they're on it for that
I don't
long?
know. I don't think that's ever been studied. I'm not really sure. But I do know that untreated catatonia will definitely reduce life expectancy if they're
Right,
frozen, they're not
right.
eating. So I mean, you have to document all that stuff. Yeah.
Yeah. Okay, thank you.
Yeah, I mean, like I said, when you start treating very severe patients like I have, and I still do, you have to make exceptions, right? But you have to understand what the risk benefits are, and you have to make sure that you do a good informed consent with the patient and the mother. Right now, she's an adult, but she can decide if she wants to stop it or not. But when it comes to deciding the medications, you have to do informed consent for the guardians, the parents, and the patient.
What's the first line you use with catatonia then? Do you go right to a benzo or?
Yeah, Ativan challenge. Ativan challenge. Give them IM Ativan and they snap out of it. What do you think that next psychiatrist would have tried with taking on that? To be honest, I have no idea. I don't know.
ECT maybe, right?
ECT, yeah, it's another option. Could be. Yeah. But again, it doesn't hold its charge though. Some people get ECT and the catatonia goes away for a few months. Sometimes it comes back and sometimes so what usually we do is that we'll try the benzo challenge, right? Because it's the least, ECT, you have to be admitted, there's a whole process about it, right? We'll try that first. Sometimes we'll do, and they don't respond to the Ativan, we'll do ECT, and then we'll continue with a maintenance dose of Ativan. Sometimes patients respond to that, right? Sometimes benzos don't work at all. They just have to do ECT a few times. But no one really knows, what the long-term consequences are of chronic ECT. Nobody knows. It's uncharted territory, so yeah. But catatonia is, it's one of probably the most severe symptoms someone can have because, they literally will not eat, not talk, and, they'll rot to death. They won't do anything. They'll be like a statue. I will let you know though, if you work inpatient, a catatonic patient can hear. When I was inpatient, the catatonic patient snapped out of catatonia. They were on a one-to-one. And the patient was like, listen, I know everything that all those staff members that were sitting in the chair talking on their phone, I knew everything that they were saying. This means they're not talking, they're not responding, they hear everything. So I used to tell the one-to-ones, like, listen, don't talk on the phone, do what you need to do, watch the patient, make sure that they're safe, because if you talk on the phone, they're going to hear everything that you're saying. Just because they're not responding, they're not externalizing, doesn't mean they're not internalizing. They want to talk. Imagine how scary that is for a patient. Someone's talking to them, they can't move, they can't talk. It's almost like compartment syndrome, right? You're frozen. You can't communicate with anyone, but they're talking to you. So it's a horrible disorder or symptom to have.
It's Professor, it's always part of like a schizophrenia diagnosis. It's never like a
No, not
standalone
always.
catatonic
No, not
diagnosis.
always. Not always.
No?
No.
Sometimes it's
I've
like
seen
a standalone
catatonia in
catatonic
very bad
diagnosis.
bipolar 1. I've seen catatonia in very bad. It's pan-diagnostic. It can happen in all different presentations, right? Catatonia can also be infections. Yeah, so you want to rule out what the cause is. If it's psychiatric, you want to treat the underlying psychiatric cause also. So that's another, I didn't want to touch on too much, but since you brought it up, if someone has catatonic schizophrenia, they usually don't respond just to Ativan by themselves. You also have to treat the schizophrenia. So they have to be on both an antipsychotic medication and a benzo. All right, that's important. If you stop the antipsychotic medication, there's a chance the catatonia could come back. And there's also excitatory catatonia, which is very interesting. Listen, you guys asked me about catatonia, so now you're going to get the whole thing. There was a patient when I worked inpatient in NYU that he would run out of his room and he would break the exit sign for whatever reason. Not goal-directed behavior. Just run out, sprint, break the exit sign, calmly walk back inside his room and go to bed. Not say anything, not talking, not talkative. And we called on-call psych and they would always IM the patient, right? I wasn't NP at the time. I was still NP. I was in NP school, but I was smart enough to say, hey, this doesn't seem like psychosis to me. I was like, I'm learning about catatonia now. Could it be excitatory catatonia? So they're like, you know what? Since we IM'd them to antipsychotic, let's do Ativan for the next one. They gave him Ativan. The patient was talking, communicating, and he had no idea what he was doing. He didn't know he was running outside and smacking the sign and breaking it. So it could be excitatory, right? Where someone's doing, so you do something called the Bush-Francis Catatonia Rating Scale, or BFRS. And there's a whole bunch of questions there. And based on how they score, they might be classified as, severe excitatory or, stuporous catatonia, right? The opposite, in which they're not doing anything. But the goal is non-goal directed behavior. They're doing stuff that doesn't make any sense. It wasn't like he was trying to leave the unit and break the door down. He was just breaking something randomly and then going back, right? They have echolalia. They might repeat what you're saying. They might have echopraxia, repeat the things that you're doing. They might follow you around the unit, right? They might have negativism, where they'll just say no to everything, right? These are all symptoms of catatonia. There's a whole bunch of symptoms, but there was just some of them. There's also, it's called the ballerina pose. So what I do is, if the patient has catatonia, you put one hand over their head and one hand like this, and they stay like that. It's called the ballerina pose. And they'll stay in that pose for hours. Hours. They won't move. Yeah.
How does their arm not get tired?
Guess what? It's against gravity. I had a patient when I was doing child psychiatry and I was covering the child psychiatry unit, and he was getting out of bed. You know when you get out of bed and you go on one foot on the bed and you're like one foot's about to step but it doesn't step? He was stuck like that for hours. One foot on the floor with one foot about to step, but he never stepped against gravity. Like I couldn't even do that. Like a gymnast from the Olympics wouldn't be able to do that and hold that pause.
How old?
He was 17. So it goes against gravity. People will have the weirdest poses and they'll stay there. So that's why you know they're not faking because they'll just stay in a very weird pose. Yeah. Whether it's like mid walk, where they'll be like walking and they'll just stuck like that, right? One foot's up, and they'll stay in one foot for hours. It's against gravity. It's such a weird. If someone tells you that medication is bullshit and that you can treat every mental health issue with just psychotherapy, tell them I want you to treat a catatonic patient with psychotherapy and see how that works out. Right? This is one of the instances in which psychotherapy is not going to help a patient at all. You need to treat the underlying issue.
And it's really just like benzos, right?
Benzos, yeah. Ativan in particular. Yeah.
And like, what's this? Like, IM benzos obviously would be for inpatient, and PO is for outpatient. And the reason that you would give IM inpatient
Because IM is
because they can't
preferable.
swallow sometimes.
No, you need IM because it needs to hit a peak plasma concentration, and you can't get a peak plasma concentration effectively with just PO doses. Because remember, the bioavailability is not going to be enough. You take a PO
But you,
dose, it's going to get eaten up by your stomach acid.
They also
So,
refuse to take the PO. Like I
yeah,
saw
that too. Yeah, they'll refuse the PO, so you have to do IM usually.
or they like won't, they're like you say, they'll become frozen while you're
Yeah,
trying to give them the med or something, and you
yeah.
just can't, it's just not possible.
So a
wait,
lot of
so
times, yeah.
anytime someone has catatonia, you have to start it on IM, the benzo. You can't ever start PO.
Most of
Or
the time they're
almost
not
always.
talking, they're not swallowing. So I mean, from a practical standpoint, and the peak plasma concentration is not going to be enough. So the problem is you calculate the maintenance dose based on the dose that gets them well in the hospital. So for instance, you IM somebody, I don't know, Ativan 6 milligrams, right? You're gonna dose the PO dose based on the 6 milligrams. But if you're giving someone a PO dose, let's say, I don't know, theoretically, they're like, I don't want IM, I have my rights, I know I have some catatonia, but I'll take it by mouth. You tend to overestimate the dose with a PO dose because it's not going to hit peak plasma. Because you might have to give them, I don't know, 20 milligrams of Ativan, right? Is that something you really want to maintain outpatient? Probably not. So if you give them an IM, you don't have to maintain them under such a high dose because the IM is already going to kick in, hit peak plasma concentration, and you can just maintain that as a maintenance dose. If you just do PO, you can overshoot it, and they might be at a much higher dose than they really need outpatient.
So
Does
they
that make
kind of
sense?
always have to be admitted if they're catatonic because they need the
Yes.
IM.
Yeah, it's a medical emergency usually. Yeah.
You can't give IM ever outside of an inpatient.
No.
Okay.
Except long-acting injectable, but not like an IM, like LAIs, like if someone's outpatient. I used to have a traveling nurse that worked for me, and I would send him to the patient's home, and they would give the long-acting injectable in the house. Then they will come back, yeah, as a service for them.
How frequent is catatonia?
It's rare. It's fairly rare, and that's why it's rare enough that if someone developed it, I would probably do a medical workup first and send them to the hospital and make sure they do a spinal tap, do CSF, and check because sometimes it could be something called NIMDA encephalitis, which is you don't want to treat someone that has that with an antipsychotic medication. You know, if you guys ever read that book and saw that movie, it's called Brain on Fire. The girl went to different psychiatrists and was given all these psychiatric medications. And then they realized that it was an infection called anti-NMDA. So what it does is it causes your body, it's an autoimmune response. Your body will start killing off your NMDA receptor sites. And when you start kill off your NMDA receptor sites, what happens is you can become psychotic, right? Same as like PCP. What's PCP? It's a NMDA antagonist, very potent NMDA antagonist. So it's like being on PCP because all your NMDA receptors are shot. So we do anti-NMDA antibodies in the hospital, and we check and rule that out. That's something you would collaborate with neurology anyway. That's not something we would treat by ourselves.
There's that movie Awakenings. I don't know if you remember with Robert De Niro. And it was also that patients were in the catatonic state and they gave them, I forgot what the medication was, and that was the breakthrough, they all got better.
Hmm?
It's a very famous movie, long time ago though.
Really? Okay. Awakenings is called Robert De Niro?
Awakenings with
Okay.
Robert De Niro. Yes,
Okay.
that's this psychiatrist Sachs.
Okay.
Yeah,
Yeah. I've heard of it. I haven't seen it. Yeah.
Jeffrey. Is it Jeffrey Sachs
I don't
or
know his first
something?
name, but I know
Yeah.
who you're talking about. Yeah.
Okay. So it's about his discovering.
Yeah.
Yeah.
I tend not to watch like movies based on psychiatry because I always find something that's like wrong, and I fight with my wife, which is like, look what they did. And I'm like, that's impossible. You can't. 'Cause it's always in the movies, like the psychiatrist always comes and IMs the patient in the neck. Do you ever see that when the patient's like agitated? They always like push the neck back and they stab them in the neck. I'm like, why would they do that? Why do they need to? You don't have to get the neck, right? There's no. But it's in movies it's always like so I'm always like I don't want to see it. This is bullshit. I did do a consultation for a writer that was trying to get a screen. He was doing a screenwriter for a show he was proposing for CBS. It was one of the guys that he was writing about was supposed to have catatonia. So he had me as like a consultant, and he asked me about the presentation and does this seem like realistic? So I did a little bit, but unfortunately, they that also happened during COVID, so his show never made it to production. But the everything's written down though. I guess the screenwriter's all there. So if it ever comes to TV, I'll let you guys know. You'll see me on the credits. All right, anxiety, PTSD. All right, so treat SSRIs, SNRIs to help with the general maintenance, right? But CBT will also be needed or EMDR, some kind of trauma-focused therapy to benefit the patient, right? If they have nightmares, treat that with prazosin, which is off-label but with evidence, right? If you guys are interested, there is a study by Raskin, Raskin, Raskin et al. That's he did the study with PTSD patients who came back from war veterans, and he went very high with the prazosin also. So I think he went up to like 16 or 20 milligrams with the men. And I think 6 or 8 milligrams with the females, around there. Don't quote me on that. I'm just citing what I remember. But the good thing about that study is that it shows you that if patients are afraid to go above 1 or 2 milligrams, there's a study that shows with evidence that you can go a little bit higher and it's safer. So if patients are not having side effects like constipation, dry mouth, orthostasis, it might be worth it to say, let's go a little higher with the prazosin. Obviously, you want to give them time. I wouldn't escalate it maybe, every 2 weeks, I would go up by 1 milligram maybe. I wouldn't escalate it like every 2 days or every 3 days because they're going to have more side effects. So just go slowly. All right. If you feel like the GAD symptoms are not getting better, then obviously you can use, the alpha 2 delta ligands like gabapentin or Lyrica off label. But it also could be an option. And benzos. Oh, going back to what I said, I do use benzos, you know, liberally because I see patients that are very treatment resistant. They never run out early. They already have it documented. They've tried all the other options. So, if you've escalated, the risk benefits that, I try to use it sparingly, but I do use augmentation with benzos. And I try to tell patients, try to use less if you can. All right. And I try not to renew it every month if I can get away with it. So I always use lowest effective dosing of benzos. I tend to use Klonopin a little bit more. It does have, longer duration, longer activation, and it's not super lipophilic, so there's less risk of, abuse with it, even there is always a risk of abuse, right? The more lipophilic a medication is. The funny thing about benzos is that the half-life sometimes is not indicative of because look at the half-life of Xanax. The half-life is like 11 hours, right? But why is Xanax only lasting like 1 or 2 hours? And why does it work so quickly, right? The half-life is so long because it's very lipophilic. So the more lipophilic a medication is, that just means the faster it crosses the biphospholipid bilayer of the brain, the more it can reinforce the nucleus accumbens, right? And cause, euphoria, tolerance, right? And is more likelihood of them being abused, right? So Klonopin tends to be a little bit less, so, I tend to lean on that a little bit more.
When prescribing a benzo, when do you get concerned with the risk of seizures from not taking it consistently or from dependence?
Well, there's always that risk, right? So the challenging part is if a patient is a very high dose of benzos and then, they lose it, quote unquote, or they go on vacation, they left it at, and this happened with a patient of mine. He had left his meds and he was on a pretty high dose of Ativan at the airport. And he even showed me the police report that he did at the airport. And, I did one. I said, look, you have the police report because you have to document that too for the pharmacy. The pharmacy might not fill it early. So you have to say, look, patient lost it at the airport. There's a police report. It's only happened one time. Can you please refill it early? But you can't do it like all the time. So yeah, you don't really want patients to have withdrawal. But you know, the patient also, they have to have responsibility because they can also go to emergency. Like I've had patients also where they do it multiple times. Like, listen, I'm not refilling it anymore. This is the second time this has happened to you. You need to go to the emergency room. The emergency room will give you a 3 day, supply, help taper you off it, and you document it. Right? I've had patients tell me, I'm sorry, someone broke into my house. They stole my bottle of Xanax. Really? Did they steal your underwear? No, but they stole my Xanax. I don't believe you. That's all they stole. They didn't steal money. They didn't
What
steal
do
your
you do
jewelry.
in that
Huh?
case? What do you do in that case? Because you can't prove they're lying or like,
Like I said, I give everyone a one, you can use it one time. That's it. What you can give me you can give me an outrageous story, right? Someone stole, whatever, one time. That's it. But other than that, then I'm not going to fall for it twice. And I tell patients
But
that.
the bottom line, Professor, like for someone you're introducing to benzos, like a new guy, you tell him, hey, listen, try to not take it so often. There's obviously not much risk of seizures there, right? If he doesn't use the month's dose in time of the month, he like stretches it out for like 6 months. There's no risk of there.
Yeah. So remember, the risk of seizures, if you can remember, is the fact that their body's
Used
getting
to it.
GABA. So when you increase GABA, which is an inhibitory neurotransmitter, your other neurotransmitters are going to escalate in response to that, right? Norepinephrine is going to go up. So what's going to happen is if you take it long enough and that accommodation happens with those other receptors, then yes, you'll have withdrawal. But if you're taking it short term, then that accommodation is not going to happen, right? Because your receptor is not constantly being innervated with GABA. So therefore, in theory, it shouldn't happen. But there's
what
always
if,
going to be a risk, right? Now, the thing is, what if it's a patient's on lamotrigine and on benzos? The risk is less. You're on anti-epileptic. I might be more, I'm not saying you should do this, but I might not be as worried of seizures then if they're already on, what if they're on Depakote for, bipolar mania? I'm really not that worried about seizures. You're already on an anti-epileptic medication. So it really depends on what other meds are on. But what if they're on Wellbutrin? Other meds that lower the seizure threshold? Then there's going to be higher. What if they're on Wellbutrin and they have a history of drinking alcohol? Then it's going to be a higher risk, right? So topiramate, lamotrigine, meds that kind of protect against seizures, I'm less likely to worry about that. But if there are other meds that lower the seizure threshold, like Wellbutrin or Auvelity, right, I might be more worried about that.
what
I have an
happens if
SSR.
like,
Sorry, go ahead.
Yeah, Madison?
I was just gonna say, what happens if like, for example, like that does happen and it's a point where like you're not gonna refill it because say it was their second time or whatever it is, like, and they can, you're risking now them going through withdrawal. Like, what happens then after you now decide to not fill it for whatever reason?
They would have to go to the emergency room. And if they really were at risk of withdrawal, they would probably detox them in the hospital.
So you would always tell them when you say no, like, I recommend, like,
Yeah,
if it,
I recommend to go to the emergency room. Yeah. And let they get filled there. Yeah. And
okay, okay,
yeah.
yeah.
Because again, the liability was on you, right? Once you're prescribing, that's going to be on you. So you have to justify why you renewed it and why you did the stuff. So if there's no way you can justify it, to me, it's not worth it. Yeah.
For the SSRI-induced liver injury, like how careful are you with that? Like if you have a patient and they have like relatively elevated liver enzymes, let's say on the low end of too high, are you gonna avoid the class altogether and go straight to second line, or do you just accept that risk?
No, you just refer them to their primary care doctor. You get a second set of eyes, and if they want to order a liver ultrasound, they could, and just to cover you.
Mm.
I thought it was SNRIs or because,
SNRIs, that's what I meant. Yeah, SNRIs are the ones that cause, yes,
yeah, okay,
Oh,
thank you.
liver injury. Yeah, correct.
fine.
SSRIs, the medical stuff I usually see is like hyponatremia, right? So it causes something called SIADH, which is symptom of inappropriate antidiuretic hormone, right? So your body is going to produce too much ADH, and what's going to happen? You're going to retain water. When you retain water, sodium levels are going to drop, right? Based on diffusion. So if you're on another med that also contributes to like carbamazepine, which also has a risk of hyponatremia, then the risk would be much higher. So sometimes when two meds are combined that have similar risks, there's going to theoretically be a higher risk of that side effect, right? Like two meds that block alpha receptors, or a med that blocks beta and alpha receptors, obviously is going to be a higher risk of orthostatic hypotension, right? Or low blood pressure, or dizziness, or risk for falls. if there's meds. I've seen this also. A patient is on a D2 blocking agent, right? And they go to a GI doctor and they get put on Reglan for nausea for whatever reason, which is also a D2 antagonist. What do you think the risk is for? Side effects of D2 antagonists, we'll talk about when we talk about antipsychotics. But whenever there's risk of compounding risk, there's always going to be that risk of double jeopardy, right? The same side effects. And sometimes, you know what? Since we combine mechanisms, not meds, sometimes they combine meds with side effects that kind of complement each other, right? Like I'll give someone an alpha 2 agonist that can cause sedation and relaxation together with Adderall, which can increase anxiety. So they kind of complement each other, right? So I give it to them at night so they can sleep better, but it also helps with ADHD. So an alpha 2 agonist with stimulant is rational polypharmacy, right? You're doing two meds with complementing mechanisms of action to help with symptoms, anxiety and ADHD symptoms, right? You're giving someone trazodone with an SSRI, you're not combining two antidepressants. You're combining two different mechanisms of action and they're complementing each other. That's called rational polypharmacy, right? You're not going to give someone duloxetine and Prozac at the same time. That makes no sense, right? You're not going to give someone Lexapro and Zoloft. And I've seen that before. Patients are on Lexapro and Zoloft. Why are you in two meds? That makes no sense to me, right? Sometimes that happens when patients are caught in the cross titration where someone is like titrating one med off the other, which you're gonna talk more about switching meds during 517, 27, 37, 47, because you're gonna have case studies about that. But in general, when we switch meds, we do cross titrations, right? You're lowering one med and you're going up in the other. But there comes a point in which when one is like middle of that dose and the med you're starting is at the middle of the dose you want to hit, so they're stuck on two meds. What do you do for patients that I feel fine on this? I want to stay on it. I usually recommend to avoid polypharmacy that makes no sense, right? Because they're two meds that do similar things. We need to continue with the cross titration. Let's get you off that first med because it wasn't really helping you. Continue with adding that second med. Now there are exceptions. There are some patients in treatment-resistant schizophrenia. Like I said, I treat very sick patients in which sometimes they're on risperidone and olanzapine and it works for them. And every time I try to switch it, it doesn't. And they've been on every antipsychotic before, and they can't tolerate clozapine. They've gained so much weight on it. Obviously, I document that even though it doesn't make sense from a clinical textbook case, right? I'm treating the patient in front of me. There's no side effects. They say they're doing better. I tried to reduce it. They get worse. I'm documenting. I'm keeping them on that regimen, right? But you have to at least try to get them off one med instead of just keeping them on two meds if they don't need to be, all right? I even have patients on three antipsychotics. I've had patients on clozapine, risperidone injectables, and Abilify. And we'll talk about when that might be needed for somebody. There's specific patient presentations where you might need that. It's rare, but it could happen. And we'll talk about that in schizophrenia. But, try to combine rational mechanisms of action, right? Don't give an antihistamine and modafinil. Don't give like a beta blocker and a beta agonist for asthma. You know what I mean? You don't really want to combine, you know. And sometimes there are some cases in which in textbooks it says this, but in clinical practice, like for instance, someone might be on an antipsychotic med for mania, right? But they have comorbid ADHD and their mania is controlled. So you have them on a D2 blocker, but you also have them on Adderall. So based on mechanisms, you might think it might counteract, but for some reason it still works, right? Because in theory, the dopamine is just increasing in the dorsolateral prefrontal cortex, right? Like that first question I asked you in the first exam, but it's not increasing in the mesolimbic pathway, which is the psychosis or the mania pathway, right? For whatever reason, the antipsychotic is blocking too much dopamine in the mesolimbic pathway, but it's not blocking too much in the dorsolateral prefrontal cortex, and the patient is still getting that innervation and they're able to focus, right? Sometimes increasing dopamine or epinephrine can worsen anxiety. So that's why Wellbutrin sometimes, if someone has comorbid anxiety with depression, and I feel like they're both kind of equal, I'll stay away from Wellbutrin because they might sometimes be too stimulating for patients. But there was a recent study that debunked that and said that patients who had MDD with anxiety as a aspect of the MDD actually did better, or the anxiety wasn't worsened with Wellbutrin. But like I said, it's hard to know which is which. So you could technically try the Wellbutrin monotherapy, but if the anxiety gets worse, you have to add an SSRI on there or something else to help with the anxiety or an SNRI, right? If someone, you can combine an SNRI with Wellbutrin, but what are some things you should look for with the patient? What should you monitor? Which
Blood
vital sign?
pressure.
Blood pressure and heart rate. Very good. So you can combine them. What if someone has allergic depression, right? With anxiety. They have low energy, can't get out of bed, so you need to increase norepinephrine, right? They have low motivation, so you have to increase dopamine, right? They have poor concentration, the D's, the A's, avolition, anhedonia, inability to feel, pleasure. So usually those are dopamine driven, right? The funny thing is that when we talk about substance abuse later on, I know I'm bouncing around, but I'm just trying to make it interesting for you guys. There's two types of, you know, pleasure, right? There's seeking, it's like reward. Like I'm anticipating something, right? I can't wait till, I get paid this Thursday or whatever, right? And then when I get my paycheck, there's that feeling that I get when I cash it in the bank, right? So there's the anticipation, and there's also when you get it, the reward. The anticipation is usually dopamine driven. So if someone says, I have nothing to look forward to, I have a vacation that's coming up in 2 months with my wife, but I don't know, it just doesn't, I'm not even looking forward to it, right? That's more dopamine driven. If someone says things that I used to enjoy doing, like, when I used to enjoy getting a new movie or listening to new music, it just doesn't feel the same anymore, right? That's probably more opioid driven. That's more opioid receptors, right? So there's looking for something or anticipating something, and then actually getting that reward, there's different pathways there. So sometimes based on what the patient tells you, you might have to target different receptor sites. Yes, question, Joseph? Raising your hand.
How would you target that anhedonia specifically?
Which one? Which anhedonia?
Well, you just mentioned it, like someone who doesn't get the reward from doing the thing that they enjoy doing, that in the moment
So
pleasure.
that's challenging because we don't really have many medicines that work on opioids, but one that we know actually is Auvelity. The dextromethorphan works on opioid receptors also. Yeah,
Well,
yeah. And they're trying to find other investigative receptors. There's also some evidence that using low dose naltrexone. Now you would wonder, why would an opioid antagonist, work with reward pathways? Now no one really knows why, but some of the speculation is if you block the opioid receptors, what's going to happen to those receptors? They're going to upregulate and become more sensitive. So by upregulating and become more sensitive, maybe that's helping, But again, that's just one of the hypotheses, right? So maybe using low dose naltrexone can help with patients that have that kind of anhedonia. There have been some small studies that show that. But like I said, I mean, pharmacology is so interesting. I mean, I love this stuff because just understanding the mechanisms, how you can help patients and kind of find and tailor your own treatments. The only way you can do that is if you understand the mechanisms, right? But if you just memorize meds based on diagnosis, you're not going to get to this level, You're not going to be able to kind of figure out complex regimens for your patients. It's the only way. So GAD and PTSD, they're very short lectures. What I'm probably going to do next week uh, is I'm going to review bipolar again, MDD, because I know you're going to get another review with Professor Stern, so it'll be good to get it. And I'll kind of, go over like lithium again, Depakote, carbamazepine, and the nuances of those meds. You know, is there any questions that you guys have? I mean, anything about anxiety or anything that you guys read that wasn't clear?
So obviously there's the differences in treating anxiety versus MDD versus PTSD. Like, I guess mostly the differences are like not not that there's not differences pharmacologically, but like for example with PTSD, you want to incorporate like psychotherapy,
Mhm.
certain dosages, things like that. Like the medications that treat MDD, anxiety, and PTSD for the most part are usually the same types of meds.
Usually, if you look at the mechanisms and understand how the receptors and the neurotransmitters affect the brain, yes, they're very similar, right?
Okay.
I'm sorry, guys. I didn't talk about PTSD. I didn't talk about OCD. How can I forget about OCD? Obsessive compulsive disorder. I forgot about that. So when I was talking about the dosing, usually, you know, a little bit higher dosing for anxiety disorders, but PTSD, sometimes you have to go super therapeutic, which means above FDA indication. So sometimes I've actually had patients on 400 milligrams of sertraline. What is the FDA approved dose of sertraline? 200 milligrams. I've doubled that. So there's actually studies that show that for treatment-resistant PTSD or very difficult to treat PTSD, you actually have to go super therapeutic. Super therapeutic with the Prozac, super therapeutic with the Zoloft. So you have to push it up a little bit higher. So PTSD sometimes so there's a concept that I teach called MIS diagnosis, which is MISDIAGNOSIS. So it's a misdiagnosis, right? You diagnose someone with depression, but it's really bipolar depression, right? And there's MISSED diagnosis, in which someone has a comorbidity, but you missed it, and the person's not getting better. Like for instance, you're treating someone for depression or GAD, but they have a comorbid OCD, which you didn't screen for. You didn't do a Yale-Brown obsessive compulsive scale or a YBOC, and the patient's not getting better. So obviously the OCD is a part of that also. So they're not feeling better because maybe the depression is a little bit better, but there's the OCD intrusive thoughts that are still there, right? So how do you screen for OCD? You can ask the patient very simply, have you ever had a time in which you woke up in the morning, right, and you had a thought and an idea that popped into your head and it stayed there the whole day? No matter how hard you tried to get it out of your head, it stayed there, it persisted. It's an idea or a thought. And in order to alleviate the anxiety from that idea or that thought, you try to do something else, like counting numbers or washing your hands or doing certain routines, right, or compulsions and help to alleviate the anxiety from those intrusive thoughts. When you let the patient sit, right? Because people sometimes will have, it's not always germs. I know that's the most common that society thinks about, but OCD a lot of times is actually a lot of like very, very taboo topics, right? I've treated patients with OCD with they have a voice tells them they're a pedophile, a voice that tells them that they're gay, a voice that tells them that they're a lesbian, right? But the point is, it's ego dystonic, right? There's ego syntonic that feeds the ego where it actually helps them, right? So there's OCPD, which we'll talk about personality disorders, where people just like, to do things a certain way, right? I like to organize stuff a certain way. If you disrupt it, it bothers me. That's called OCPD. There's OCD, which is obsessive compulsive disorder. It's ego dystonic. There's an idea or a thought that pops into my head, but it bothers me. I'm not a pedophile. I don't want to kill anyone. I don't want to kill myself. Sometimes when patients have chronic suicidal thoughts, it's actually OCD. It's not depression. People miss this all the time. I'm telling you. You ask them, do you really want? No, I don't want to kill myself. But there's this voice or this idea that keeps popping into my head about different ways to kill myself. But it pisses me off because I don't want to kill myself. Right? But I
I've
can't
heard
get
of
an idea out of my head. Yes.
I've heard of this before, and I've heard that like apparently I was reading this like a while ago and you're like making it pop into my head now, but how you were saying like a patient's like, no, I don't want to kill myself, or like I'm not a pedophile or whatever. I heard that they say it comes from like the fact that it really isn't true, but you have anxiety about it because you know it's not true. Like, is that
I don't really, I mean, there's so many different theories about it. And I mean, I'm not a psychotherapist and that deep in it to really go there, but I do know that it bothers them and it makes them feel uncomfortable. So I'll just keep it very general, right? So sometimes what happens, like in a neurobiological sense, right? I can speak from that, not from a psychotherapy sense, is that there's a part of our brain called the anterior cingulate cortex, the ACC, which is called the error correction part of our brain, right? So sometimes when you close your door and you lock your door or you do something, right? Your anterior cingulate cortex is innervated by serotonin, right? It's going to hit it and say, you know what? You're fine. You did it. You're good. You can move forward and do what you need to do, right? But for patients who have OCD, for whatever reason, there might be a misfiring in that anterior cingulate cortex. And what happens is they don't get stimulation from that serotonin and that network, right? So that they're constantly checking, like, oh my God, I don't feel comfortable. Like, did I really check my door? And they check it again. And what happens is it becomes a habit and it becomes a compulsion, right? And it follows that pathway that Stahl talks about, the cortical striatal thalamic cortical pathway, the CSTSC, right? And it becomes a loop, and people obsess about it, and they can't stop. Check my door one time, I gotta check it twice, and I keep because every time I check it and I walk away from it, I don't get that feeling of, you know, it's okay, I can go, right? That part of my brain that tells me it's all right, the anterior cingulate cortex, is not being innervated by serotonin, and I can't move forward, right? So by giving someone an SSRI, one of the theories that it might help correct that pathway. So you get that innervation with serotonin that you don't have to check your door 100 times, right? Or you
and
don't have
that's
to.
OCPD, right? When
No,
you
that's
do
OCD. No, that's obsessive compulsive disorder.
Oh, I think it was okay, and then OCPD is like the thought that bothers you.
No, no, we're not talking. Forget about OCPD. We're not talking about OCPD
I'm
anymore.
erasing it from my notes. Okay.
Everything
So
is
OCD
OCD.
is
This
you
is all OCD. This is all OCD.
do things a certain way.
This is all OCD. Obsessive compulsive disorder. Yeah. For OCPD, I'm not aware of any evidence that shows that giving someone an SSRI will help with it. Yeah. Yes, Elizabeth.
So what's the difference clinically between like rumination and OCD? Will it be that the person has to
Rumination is
have
part of,
physical
so OCD is like
symptoms?
the umbrella term, right? Rumination or obsessive thoughts is like you ruminate. You're constantly thinking about it, so you can't not think about it, right? You're obsessing about it. So I'll give you an example. Sometimes OCD could be a missed diagnosis because it's one of the symptoms that you missed and you're treating depression, but you need to go higher to treat it. Or it also could be a misdiagnosis, MIS, in that you treat someone with ADHD medications, you think it's ADHD. The person's like, I can't focus in school because I keep having to reread that same page over and over again, right? If you just take that for face value, all right, why are you, is it because you're not retaining the material? Is it because, you feel like, like, because it also could be OCD, right? I have to read the page 10 times in order to get it into my head. There's a certain way of doing it, or
So
else.
OCD is more about like the act of doing something to kind of counter that thought to stop the thought. So it's
If you have
not
a compulsion, yes, the compulsion will be there to ease the anxiety of the rumination or the intrusive thought. That's correct. Yes. But there's some people that have OCD but don't have compulsions. They don't have rituals, but they do have
that's
intrusive thoughts.
that's my question is
Yeah.
like how do you
You
differentiate?
can. You can have OCD and just have intrusive thoughts, but not have compulsions. I always ask about that. Some patients will say, yes, I wake up in the morning and I have this thought. It keeps popping into my head. It really bothers me. Do you do anything to help soothe? No, I don't. I just deal with it. So that's OCD, but it's not, there's no compulsions there. So you could treat that with high dose SSRIs. And sometimes in therapy, what they do is if someone has a thought, like someone can have OCD thoughts that are grounded in reality, right? Or some people can have OCD thoughts that are very bizarre, right? Like if I don't do this, aliens might come tomorrow and, or I've even had patients say, I'm the one that caused COVID because I didn't count to 5 that day. Now I keep counting to 5 because I don't want COVID to happen again. I have
Is
to,
that
every
like
time I open my door.
psychosis though too?
There is something called schizoobsessive disorder, which could be related to schizophrenia, but that's a separate topic. But we'll keep it very simple now. There's OCD that could be bizarre. Well, they'll have these very strange, obsessions that are not rooted in reality. The reason why I bring that up because sometimes SSRIs by themselves might not be enough, and you might have to give a low dose antipsychotic to get that out of their mind. Now, I'm not saying they have psychosis, right? I'm not diagnosing them with psychotic disorder, but they might have treatment-resistant OCD because their OCD is kind of getting close to that spectrum of psychosis, but it's not because you can still challenge it, right? Someone who has psychosis sometimes their volition is very strong. No, I did cause COVID because I didn't count to 5. Is it possible? No, I did. I caused it. Someone that can challenge that and say, there's a possibility. Yeah, there's a possibility that I didn't cause it. Yeah, there's a possibility of overthinking it also, but I can't stop thinking about it. See the difference there? It's a nuance. It's very nuanced, but it might, help with the treatment of the patient.
I guess it's the awareness that these people know that that's not true, but it's still happening to them. While in psychosis, they truly believe that that's what it is.
Correct. Despite the keyword there is despite evidence against it, right? Despite
Exactly.
there's evidence that what you believe is not true, you still believe that it's true, and you feel that the evidence is not. There's so much evidence saying that, I don't know, the Earth is flat, right? The Earth is not flat; it's round. Sorry if you flat earthers, if you guys are flat earthers, I apologize, but um, the world is flat. I don't. Space is fake, right? But what about when you're on a plane? You can see the curvature. No, the mirrors of the plane are just like that, right? Despite all, and meanwhile, their belief there's more, and they have to like change everything to shape that belief, but they do, right? So that's kind of like psychosis there. Despite everything that's showing that that delusion is not true, they believe it, right? By the way, when we talk about schizophrenia, I love psychosis. Schizophrenia is like my thing. We'll talk about that, all this stuff, all the different types of hallucinations and delusions. I've seen all of it. I even had the Capgras delusions, the very scary one. I've seen a few patients. Like Capgras means that you believe that your family is not your real family, that they were kidnapped by imposters, and that if you don't kill the imposter, your family is never going to come back to you. I've treated patients with that also, Capgras delusions. But we'll talk about that when we talk about schizophrenia.
I once had a BHA tell me he didn't believe in rockets, so rockets were fake and flat Earth was real. It gets funky out there. Just to sum up, though, for anxiety, for panic, for all the anxiety spectrum disorders, FDA approval is basically SSRIs and SNRIs, and depending on acuity, maybe benzos. Do I have that right?
Yes, correct. Yeah.
Cool. Thank you.
I'm not gonna, I probably shouldn't say this, but I'm gonna say it anyway. I'm not gonna ask you questions about FDA approval, about the med, which is FDA approved and which is not, but I will ask you about mechanisms of how they work and how you would prescribe them. The reason why, because the test is only 50 questions and it's such a big topic that I don't want to waste time, but because FDA approvals always change. Sometimes meds get new FDA approvals, and you can always look that up. So from a practical standpoint, I don't think you guys need to memorize that, but I do want you guys to understand the mechanisms, the CYP enzymes, in general, how the meds work. Yes, Tom.
So we don't need to know like specifically which SSRI is approved
No,
for.
you don't have to know that.
Okay.
Keep that in your back pocket. Like I said, I try to make this class like enjoyable and that I'm not trying to like, stump you guys, but there are things I'm very passionate about. Mechanisms of action, pharmacokinetics, pharmacodynamics. FDA indications not that important because that changes sometimes, right? Meds get new FDA indications and some get pulled for whatever reason. So that can always change. So that's not in flux. That's in flux, I mean. That's not but I do, like if I do, for instance, I might ask you a question, patient has obsessive compulsive disorder. Your plan is to start an SSRI. When talking with the patient, would you say, A, I would prescribe you medications at half the FDA maximum dose. I would prescribe you. That's important because you have to understand that with patients, right? If you're prescribing a patient an OCD medication, you have to tell them already, I expect that I might have to go above the FDA indicated dose. Possibly. There's a possibility. Maybe not, but there's a good possibility I might have to. I want you to feel comfortable that the pharmacy might tell you the prescriber is trying to overdose you, and it's okay. I'll call the pharmacist and explain to them what the rationale is for that, but you're safe, right? I'll show you studies that show that we might have to use super therapeutic dosing for OCD, right? I might have to use some atypical antipsychotics if your OCD is a little psychotic in nature, right? Don't be afraid. I'm not diagnosing you with schizophrenia. I'm not saying you're crazy, but there is evidence that shows that sometimes a low dose of Abilify or a low dose, risperidone might help with that. Just want to make sure you're aware of that because the thing is, you want to already when you're treating a patient, right? You kind of want to have a game plan in your head already, broad spectrum, not as a microcosm, macrocosm, whatever you call it, as a big picture. Then you go micro, right? Then you can say these are the options, these are the how they're going to work in the brain. But in general, you should be able to understand it from a macro point of view, and then you can go to the micro point of view, right? I think that's important to understand as a prescriber.
So are you saying, like, for example, on the exam, you would say like we would prepare our patients that we may have to go to a higher
Yes,
dosage of an
that's important.
SSRI for anxiety?
Correct. That's an important. Yeah, a little bit higher for anxiety.
Okay.
I might even, I'm not saying these are, but these are some questions I've asked in the past, right? A patient asks you, hey, I'm curious, my friend is on sertraline 100 milligrams for depression. Why do you have me on 300, right? What would your response be to the patient? Same concept that I'm asking you, right? But it's making you think outside the box. So all the questions I write are to benefit you as practitioners, right? I'm not trying to stump anybody. The first exam is a little bit harder. I have to ask definition questions because I have to establish all that other stuff, right? But moving forward, there's going to be a lot of clinical questions, right? Patient comes to you and says, "Hey, I've started taking this medication. Does it interact with this med that you're going to prescribe me?" Right? And there might be some things that you have to know about, right? If it's Prozac, yes, your Prozac might increase the dose of your metoprolol, so I might start at half the dose, right? That might be the answer. So there might be different. So my questions are going to ask different concepts tied together. It's not just going to be one concept; it's going to be multiple concepts. But I think that's the way psychiatry should be learned, and that's the way you guys should visualize it.
Are the questions going to be like clear? Because I don't know. It's just so much material, and I don't know. I'm just asking for clarity in the questions, please, if you can, because
Well, I
some.
mean, clear is subjective, but I myself don't ask select all that apply questions. I think they're stupid. So I definitely won't ask those questions for you, right? That makes it clear. And I try my best to make it as clear as possible. I try not to trick anybody. I think some of the questions that students said were not clear were probably questions that I pulled from the question bank from the first exam because there were some questions that were pulled from a question bank, and I agree some of the wording was off. I don't think I wrote those questions, but I could be wrong. But you guys will know which questions are written by me. Trust me, you'll be able to tell. And probably majority of the questions are going to be written by me for this exam.
There were some questions I remember it was like does and sometimes does and
Oh, I don't write questions like that. That was not me.
okay, yeah, because those were like I don't know. It
I
just
try
seemed
to be as clear as possible, and honestly, even with like the answers, like I don't like if I'm gonna ask you a question, I'm not gonna put meds that are very, very close that it's like, I'm not gonna put clonidine and guanfacine in the same answer, right? Because you can argue both are alpha 2 agonists. Unless I ask specifically which medication has the least potential for drug-drug interactions, it would be probably clonidine, right? Because it's metabolized by multiple CYP enzyme. Guanfacine is only metabolized by one. But I'll try my best to make it clear. Like I said, I'm not trying to stump anyone. But at the same time, I want to tie together multiple concepts for you guys to understand it, right? Like I try to make the exams a learning experience for you to kind of be able to reinforce the material that you guys are learning. Like it's not a, hey, got you, right? I don't get off on students failing the exams, right? I really get upset when patients fail the exam. I want everyone to get an A. We have 10 minutes. Any other concepts or questions that are not clear?
So for anxiety, in those patients, you should expect them to have like elevated cortisol levels. Um, so how come we can't like test for that in like clinical settings?
That's a great question. For this class, it's like an intro to pharma. I don't want to, but there is what Thomas is mentioning is that there are some, patients that for whatever reason they have elevated inflammatory markers, right? Like TNF alpha or C-reactive protein, or you could do like all different tests, right? Just to check to make sure if there's any inflammatory markers. There is some evidence that shows that if you are able to lower those inflammatory markers, patients have better outcomes and they respond better to antidepressants. So as you guys get better, if you want to specialize in mood disorders, then reach out to me when you graduate from Stony Brook and I'll give you the tips of the trade of how to manage those patients. But Tom, these are great questions, but it might be a complicated answer for the students here, and I'll answer it in detail offline, like I usually do for you. All right. So usually inflammatory patients who have high inflammatory markers, sometimes they don't respond first line to SSRIs. I would probably use dual acting meds like Wellbutrin or SNRIs or other options besides that, or tricyclics. Because for whatever reason, SSRIs are not effective with those patients for whatever reason. And I try to get them on the Mediterranean diet, you know, exercise, things that will reduce inflammation. All right. Weight loss. They say just by lowering your BMI, your response rate to SSRIs go up a lot. So just by patients. But easier said than done, right? If someone's depressed, how do you tell them to go to the gym? It's hard. It's hard.
Do you say it though? Because losing weight like is associated with just betterment of like a lot of aspects of your life, especially mental health. Do you ever like say, listen, something to consider, or do you kind of shy away from it because it's hard?
What I do is I give patients short-term goals. So let's say, for instance, like if they've like, they have energy, I'll say, we'll start you on the meds. Now, this is something that I should mention too. There is a controversy about the box warning about increasing suicidality with SSRIs, right? I'm in the camp that believes that it doesn't do that. I believe that actually, if anything, it helps and reduces. There have been studies that show that when they released that box warning, prescribers were actually less likely to prescribe depression and they were less likely prescribing SSRIs. And actually, the amount of completed suicides increased and there was more suicides, right? Now, the thing is, the risk that we have is that obviously depression is multifactorial, right? There's inertia, there's low motivation, there's suicidality, there's sadness. Those symptoms don't improve at the same time. So there is a risk that sometimes the neurovegetative symptoms get better first, right? The inertia, the motivation, right? Now they have the motivation, they have the energy, but they're still suicidal because that's sometimes last to get better. So that's why patients are at risk of committing suicide. Now that's debatable also. But the point of that box warning is that prescribers should not be giving, 2-month prescription of Prozac after one visit and saying, come back in 2 months, has a long half-life, and then I'll adjust your meds. The point of that is you need to check in with patients more frequently. And usually what I do is if I prescribe an SSRI, I want to see them in 2 weeks right away. I see them every 2 weeks for maybe 2 months. And then after that, we go to every month, then we go to every 3 months, or every 2 months and every 3 months, right? If I work in a outpatient clinic, which I'm partnered with therapists, and they're seeing the therapist every week, then it's okay. You don't have to see me in 2 weeks. Then maybe you can see me in 3 weeks, because at least I can check in with that therapist and say, hey, how's the patient doing? Are they all right? Then I can see them on the third week. But if it's just me they're seeing, they're not in therapy, and I don't have HIPAA release forms to talk to that therapist, then I want to see them in 2 weeks. right? Because you want to make sure that they're not going to have the increased energy, the increased things. So what if someone has GAD, they're suicidal, and they have MDD? And like I told you guys, that first couple of weeks to treat the GAD, they might have increased anxiety and they're suicidal, right? There's a high risk of suicide there. So give them something for the anxiety, see them more frequently, right? To monitor them, to reduce the risk.
So is your point that like if there is any actual risk of suicide or the SSRIs, it's in that first like month introduction to the medication, and that kind of that risk goes down?
Usually, yeah, when they're, there's a chance of them being, activated, right? There's something called early activation that can happen sometimes too. It's not mania, it's just called early activation, which you see a lot in children. If you do, I do child psychiatry also, so there's a lot of stuff that happen. I was actually talking about Stony Brook doing like an elective class as like a child psychiatry class, but I don't know, we'll see. Maybe in the future I'll do one because child psychiatry by itself is like a whole different animal. There's a lot of different nuances with kids, but what did I want to talk about? Yeah, so monitor them early, make sure you assess for, increased energy, but they're still having suicidal thoughts, right? Check in with them. Find out if they do have a plan or intent, right? You guys know that already as nurses, so just make sure you do more frequent check-ins. Right. And also the LD50, which is the lethal dose for SSRIs in general, are pretty high. Like I've seen patients take a whole bottle of Prozac and they survive, right? But if someone's on tricyclics, just be aware that they take a whole week's worth and they'll have a heart attack. So just be careful. Like, I probably wouldn't give someone who has safety risk tricyclics like a month supply. Maybe give them like a couple days worth, or have the family or friend hold it and give it to them, and you sign off that that their meds are not, they don't have easy access to it.
Isn't the increased risk of suicidality in with SSRIs mostly in pediatric and teenagers?
So there's some controversy with that, and 18 to I think late 20s, 28 maybe somewhere. I always forget the exact, but around there, 18 to
Maybe
like
24, I think.
24, something around
I
there.
think I read now because I was doing that in the assignment.
So there's some controversy in that. Is it early activation? One, is it someone who actually has bipolar depression that's being put into a, mixed state, right? It could be two, because obviously when people do develop their mixed states or their mania, it's usually during that time, right? 18 years old between, 20s. So I'm sure it's a little bit of both.
Yeah.
Yeah. But definitely document, that you spoke to the patient about the risk and that, they're going to go to the ER, or they'll let you know right away if they do, if they do have those thoughts.
I have a last class
Sure.
question. Like so I know that it's very easy to throw someone into, you basically discover bipolar in someone if you give them an SSRI and they present you with MDD. So if they come to you with major depression and you don't see any symptomology that could give you a hint of mixed features or mania, but you know that they have like a first degree relative, like a parent with bipolar disorder confirmed, do you just treat it as if they probably have bipolar because because the genetic component is so strong, or do you just treat the symptoms?
That's a good question. So I need soft signs, right, of bipolar. So some of it is early age of onset. So sometimes before the age of 17, depression, of really bad depression. I'm sorry, early age of onset, abrupt onset. There's no like building up to that depression, right? Family history, you mentioned that already. Past history of poor response to SSRI. So those are soft signs that tell me that maybe this is more than depression. I have to be careful about giving you another SSRI. So say someone comes to me, because I do consults for primary care doctors, right? And they say, hey, I've had this patient on two or three different reuptake inhibitors. Do you think I should start them on another one? I'm like, well, can we do some digging? Is there a family history of bipolar? Yeah, I think the mom has it. Okay. Is there early age of onset? Okay, that's two. Is there abrupt onset? Yes, it seems like it. Three, right? And then four is that you've already tried them in multiple failed trials of SSRIs. That would tell me that I probably should put them on a mood stabilizer, or at least an atypical antipsychotic that has antidepressant properties like quetiapine, Latuda, right? Vraylar, brexpiprazole, those meds. A good question. Yeah, psychiatry gets very complex as you get better at it, but don't worry, I'm not going to ask these questions on the second exam. Just right now, just the basics. Know how to safely prescribe SSRIs, know the common side effects, right? Nausea, sexual side effects, weight gain, right? No SNRIs, elevated blood pressure, heart rate, check that. Check liver enzymes. No tricyclics could be dangerous, but could still be used. But know that tricyclics have more high risk of anticholinergic side effects, antihistamines, right? They block sodium channels, so there could be risk of prolonged QTC because they block the sodium channels in the heart. Monoamine oxidase inhibitors know about the dietary restrictions, right? And that sometimes patients could develop serotonin syndrome if you don't wash out the serotonergic medication first. Before you, let's say, for instance, someone's on Prozac, they've only been off the Prozac for 2 weeks, right? Then you start channelcyclamine, which is a monoamine oxidase inhibitor. Obviously, that patient is at risk of serotonin syndrome,
So
right?
washout is 1 month?
At least 1 month, yes.
Okay.
Like, yeah, 5 weeks to be exact, because the half-life is a week. So more than a month. All right. I guess also know the side effects of serotonin syndrome. I know we didn't cover it too much, but clonus, hyperreflexia, autonomic instability, right? Confusion. Those are the main side effects of serotonin syndrome. Sometimes I don't do this, but there was a doctor that I met at one of the conferences, and he was telling me that he keeps one of those what do we call those things? Little hammer things to do reflexes. That he says that if a patient is on a high dose of an SSRI and he's worried about serotonin syndrome, he'll do like a check to see his reflexes and his hyperreflexia. He touches it and it flicks up. So he kind of knows that, like, he's maybe going a little bit too high. I mean, I don't do that, but something to think about. Hyperreflexia can be one of the initial signs of you know, serotonin syndrome impending. Especially if you're gonna put them on like high dose trazodone or high dose Prozac, and then they're put on, like, I don't know, tramadol for pain, because tramadol is also serotonergic. They could be high risk of, serotonin syndrome. So, yeah. All right, 10:01. If I stay another minute, my wife's gonna kill me. But I hope you guys enjoyed the class. I'll upload this tomorrow morning, and again, we'll do a review next Friday, and we'll try to tie everything down together. If you have any other questions, feel free to message me. All right. Have a
Thank
good night.
you.
All right. Take care.
Thank you. Good night.
Thank you very much.
Thank you. Have a good
Good
weekend,
night.
You
Professor.
too. Bye.